Physiology of CSF and Pathophysiology of Hydrocephalus. Introduction. Dynamic component of SNES and valuable tool to diagnosis. Physiological reservoir of human proteome. Reflects the physiologic state of SNES. Historical account. Hippocrates described fluid in brain. Galen described ventricles. Vesalius showed the anatomy. Megendie performed first cisternal puncture in animals. Quink performed first LP. Dandy was credited first ventricular puncture. Quinstead did first cisternal puncture in humans. Functions of CSF. Mechanical cushion to brain. Source of nutrition to brain. Excretion of metabolic waste products. Intracerebral transport medium. Control of chemical environment. Autoregulation of intracranial pressure. Production of CSF. Choroidal extrachoroidal ependyma. Neighboring brain substance. In children with foramen of Megendie and Luschka block, spinal thecal sac still is bathed in CSF. Choroid plexectomy does not relieve hydrocephalus. Facts of interest. Only choroidal CSF production is tightly regulated active process. CSF secretion shows diurnal variation with peak in the morning. Factors affecting production. Vascular bed autoregulation. Intracranial pressure. Brain metabolism. Drugs. Absorption of CSF arachnoid granulations along the olfactory nerves. Extracellular spaces in brain. Brain substance, glial cells, factors affecting absorption. Intracranial pressure, quantitative dynamics. Daily secretion. Total CSF volume. Ventricular. Cisternal. Spinal. Techniques of CSF analysis. Lumbar puncture. Cisternal puncture. Ventricular puncture. Lumbar puncture. Diagnostic indications, infective pathology. Inflammatory pathology. Subarachnoid hemorrhage. Malignancy and spread. Pressure recordings. Cysternography, myelography. Therapeutic indications. CSF drainage. Drug delivery. Contraindications. Absolute posterior fossa mass. Coagulopathy, blood dyscrasias. Known spinal AVM. Relative. Raised ICT, guarded LP. Local infection. Technique. Positioning. Cleaning and draping. Puncture. CSF. Complications. Post-LP headaches, hematoma, infection, neural injury. Iatrogenic dermoids. Other methods. Cisternal puncture, lateral cervical puncture. Ventricular puncture. Ventriculostomy. Dandy's point, Keen's point, Fraser's point. Kocher's point. Analysis. Glucose 60 to 90 greater than or equal to 0.66, proteins 35 mg/dl 0.005, globulins 10 to 50 mg/L 0.001, RBC 0 to 1, WBC 0 to 1, L. Lactate 1.6. Diagnostic characteristics. Type. Sugar. Cells. Lactate. Bacterial. Very low. Neutrophils. Increased. Fungal. Low. LN. Dash. Viral. Normal to low. Aseptic. Normal. Postoperative. Neutrophils, greater than or equal to 1000. Hydrocephalus definition. Imbalance between production and absorption of CSF leading to accumulation of fluid in the ventricular system leading to elevation of intracranial pressure. Epidemiology. Infantile HCP, 3 to 4 per 1,000 pounds. As a single congenital disorder, 0.9 to 1.5 per 1,000 live births. Associated with SD, 1.3 to 2.9 per 1,000 pounds. Classification. Communicating aka extraventricular, non-communicating aka obstructive. Triventricular. Biventricular. Pathogenesis. Obstruction of CSF pathways leading to decreased absorption, increased production, increased venous pressure, increased production, choroid plexus papilloma, decreased absorption due to anatomical block in the pathways, block at arachnoid granulations level, increased venous pressure. Evidence with this theory. Vogue. Experimental studies in animals. Evidence against this theory. Ligation of various sinuses doesn't cause HCP. Experimental studies. Pathology of hydrocephalus. Atrophy of white matter. Spongy edema of brain. Fibrosis of choroid plexuses. Stretching and denuding of ependyma. Fenestration of septum pellucidum. Thinning of interhemispheric commissures. Acute HCP cerebral, fore or cerebellar hematoma paraventricular tumors. Gunshots. Subarachnoid hemorrhage. Acute head injuries. Shunt malfunction. Progression ventricular dilatation. Occipital and frontal horns FB temporals. Anterior and posterior recess of TV. Fourth ventricle. Third ventricular ballooning, hydrocephalic edema or available space in the cavity consumed. Stretching and denuding of ependyma. Edema of white matter. Mechanism stasis of brain interstitial fluid. Reflux of CSF into the paraventricular area. Increase in cerebral capillary permeability. Progression dorsal angles of lateral ventricle 3 to 6 hours. Centrum semi-ovale. 19 to 24 hours. Diffuse. Afterwards. Chronic HCP compensatory mechanisms and chronic HCP expansion of skull. Contraction of cerebral vascular volume. White matter atrophy and ventricular enlargement. Decreased rate of CSF formation. Diversion of CSF flow to alternative pathways. Changes in cerebral circulation. Increased venous pressure. Delayed emptying of cerebral veins. Narrowing of cerebral arteries. Prolongation of circulation time. Reduced cerebral blood flow. Lowering of CMRO2. Reduced glucose metabolism. Clinical features: age, expansibility of skull bones, type of HCP. Duration of HCP. Pediatric hydrocephalus. Enlargement of head. Thin and glistening scalp. Tense, bulging fontanelles. Dilated and tortuous scalp veins. Unilateral or bilateral abducent palsies. Cracked pot or McEwen sign. Hypopituitarism and growth retardation. Transillumination of skull. Adult acute HCP headache, nausea, vomiting, alteration of sensorium. Visual obscurations. Paranoid syndrome. Progression to herniation syndromes. Adult chronic HCP bifrontal generalized headache, vomiting. Papilledema and secondary optic atrophy. Cognitive deficits. Unilateral or bilateral abducent palsies. Upward gaze palsy. Spastic quadriparesis, dysmetria. Bitemporal hemianopia. Endocrine disturbances, normal pressure hydrocephalus. Hydrocephalus with normal CSF opening pressure on lumbar puncture and absence of papilledema. Pathophysiology. Intermittent rise of CSF pressure causing ventricular dilatation. Intraventricular pressure head is decreased. Basis of clinical symptoms. Gait problems. Urinary incontinence. Memory problems. Arrested hydrocephalus. Definitions. CSF pressure has normalized. Pressure gradient between ventricles and parenchyma has been dissipated. Ventricular size remains stable or decrease. New neurological deficits do not appear. Advancing psychomotor development with age. Pediatric NPH enlarged head usually in or above 9th percentile. History of delayed psychomotor development. Mild to moderate mental retardation. Glib verbal abilities. Mild spastic paraparesis. Hydrocephalus ex vacuo. Cerebral atrophy and dilatation of sulci. Intracranial pressure is normal. Absence of paraventricular edema. Absence of retrograde filling isotope cysteinography.